our last lecture, which was about congenital heart disease. The first one I've got is a 35-year-old woman is found to have a fixed splitting of the second heart sound. Which cardiac abnormality is likely present? Fixed splitting of the second heart sound. No, it's a while ago, but B is actually the answer. Okay, so atrial septal defect. You get that fixed splitting in the S2 and the atrial septal defect because you have all this extra volume coming from the left atria to the right atria, right? Path of least resistance, that's the flow. So right atria has a lower pressure, so that volume flow is going to go from left to right. And then all that volume has to get out of the right side of the heart. And it's going to do that by going across the pulmonic valve, which means that that pressure, that volume is going to remain high for a longer duration of time. So it's going to keep that pulmonic valve open longer, but it's going to be regardless of inspiration and expiration, like we talked about physiologic splitting of the S2. This is going to be a constant thing because you always are going to have this extra volume. You're going to always have this extra pressure on the right because of that defect. Okay. Does that make sense? Okay. Sorry, I'm missing one of the screens here. I don't know why this one's not working, so I can't have two screens to share. So, so next one, 18-year-old student presents for evaluation of palpitations. Cardiac examination reveals a continuous machine-like murmur that is loudest inferior to the left clavicle. This finding is suggestive of which congenital cardiac abnormality?
Alpha.
Did I hear alpha? Okay. And I would agree with that. Okay, there, my little notes. Yes, it's alpha. Okay. So patent ductus arteriosus, remember that's one of the adaptive things in the fetal circulation in order to bypass the lungs from blood that's already oxygenated from the placenta to get it back into the aorta so that it can go into the systemic arterial system to provide oxygen. So, but the problem with the patent ductus arteriosus is it doesn't go away soon after birth. So now, instead of oxygenated blood going from the pulmonary artery into the aorta, what's happening is you have, because now you have a higher pressure in the aorta than you do in the pulmonary artery, now you're having all that blood going from the aorta into the pulmonary artery, which now adds volume and it adds pressure to the pulmonary arterial system, which then leads to pulmonary hypertension and those types of things. So, but the classic murmur that you're going to hear in somebody with a patent ductus arteriosus is this continuous machine-like murmur, best heard inferior to the left clavicle. So where that arch of the aorta kind of terminates and transitions to the descending thoracic aorta, that's where that is going to be located. Then you have an asymptomatic 19-year-old girl, female student, who is found to have a harsh holosystolic murmur at the left lower sternal border, which does not increase in intensity with inspiration. Which congenital cardiac abnormality is likely present? So left lower sternal border, so this is the tricuspid auscultation site, right? So what is probably going on in this patient? Okay, I think I'm hearing murmurs of Charlie. Is that right? Yep. So ventricular septal defect. Okay. Now, you may be wondering, I shouldn't say I put it. The book put some extra data in here where it says it does not increase in intensity with inspiration. There's a reason for that, because what other holosystolic murmur can you hear in the left lower sternal border? Tricuspid regurg, right? But tricuspid regurg will change with inspiration. So, which I wouldn't do this to you, but if I were to have tricuspid regurg regurg is an option on this, that's not the correct answer because tricuspid regurg would change in its intensity with inspiration. Okay. So does that make sense? Just that little extra little piece of information really changes the diagnosis. Even without doing an echocardiogram, you can kind of get an idea of what's going on. Okay. And then I think we got two more. Which congenital heart lesion is associated with Turner syndrome or the 45XO when one of the sex-linked chromosomes is missing? You remember? Yeah, Charlie, coarctation of the aorta. There was two congenital disorders that we talked about, there being a genetic component to it. The first one was this one with Turner syndrome, where coarctation is common. The other one is the microdeletion of chromosome 22. It's escaping me what it's called right now, but that was associated with tetralogy of Fallot. Okay, so those were the two congenital lesions that we talked about, there being a genetic component to it, or at least put you at higher risk. All right, and then children with which congenital cardiac lesion learn to alleviate their symptoms by squatting? Okay, tetralogy, right? And the reason squatting works is it increases afterload, which then, all that extra pressure then gets translated to the left side of the heart, and it encourages less of a right to left shunt. So you're getting less cyanotic blood getting into the left side of the heart and going out to the aorta. And it's encouraging that hopefully that extra afterload, you're going to encourage more blood to get past that pulmonic stricture and go out through the pulmonic valve and into the lungs to become oxygenated. Okay, so that's how that's the physiologic change that occurs with squatting that kids with tetralogy will do in order to compensate or overcome some of the problems that they experience. So, okay, good. So today's lecture is going to be talking about pericardial diseases for the first 3/4 of it, and then we're going to talk about myocardial inflammatory conditions. So this is basically considered an inflammatory cardiac lecture. But we're going to talk about first the pericardium. Recall from lecture 1 when we reviewed the anatomy that the pericardium is this 2-layer sac that kind of surrounds the heart. And the way that it's positioned, even though you have that 2 layers, it almost is like there's 4 layers to it. But there's this fluid that exists inside. And it's only a small amount of fluid. And it's there to kind of help create a frictionless environment for the heart to work in, right? But what happens when this anatomy or this structure becomes inflamed, or that little bit of fluid in that space creating that frictionless environment becomes excessive? And now that frictionless environment becomes a kind of a excess pressure, kind of a squeezing, compressive kind of environment. What are the effects from that? And that's what we're going to talk about in today's lecture with the different pathologies with this. The other thing to hopefully remind you is the 3 main reasons that you have this pericardium is, 1, kind of keep the heart in place. So it's not swinging around freely like a pendulum, causing all kinds of problems when you're going about your day-to-day activities. The second function is it prevents that extreme dilation. Remember when we talked about how you can have too much preload, and then that starts to diminish your cardiac output. Remember Frank Starling, right? That's the pericardium helps kind of prevent that extreme dilation, so you're not straining Frank Starling and then limiting cardiac output. And then the final thing is it serves as a barrier to protect the heart from infections going directly to the heart from the other structures around it, like the lungs. But what happens when this structure becomes inflamed or excess fluid were to accumulate in that space. And we're going to talk about these four conditions and how these can interfere with the normal function of the heart. And the first one we're going to talk about is acute pericarditis. Now, if you remember your Latin, so itis means inflammation, right? Pericardium, the sac, right? So inflammation of the sac. That's what acute pericarditis is, okay? So this inflammation that develops in this condition can be either from a specific cause, like a virus or a bacteria that the patient is exposed to, or it can be actually due to a systemic disease, like a thyroid disorder can cause the development of acute pericarditis. Okay? But something triggers this inflammatory response. Now, most of the patients who experience acute pericarditis are actually not going to present to you at all. Okay? The pain, the chest pain that they have is just like, it's a little dull ache, but I'm okay. I can continue about my day. But you can see when patients do go to see medical, they oftentimes are going to be seen in the ER because what is the first thing you're going to think about if you have chest pain? What's the problem? Heart attack, right? Are you going to your primary care appointment and wait 6 weeks to get in to see them because you think you're having a heart attack? No, right? You're going to go to the emergency room. So acute pericarditis and chest pain in acute pericarditis is most commonly diagnosed in the emergency room, okay? And the most common cause of this condition is one, we can't figure out what it is, or viral, okay? So viruses are the most common cause of this condition. But when you look at the types of viruses that can cause acute pericarditis, you can see, and you probably have seen in like microbiology in your infectious disease course, these are pretty common viruses that exist, especially if you have any preschool-aged kids, right? Coxsackie virus, hand, foot, and mouth disease, right? So common. We don't think of hand, foot, and mouth disease being anything other than annoying and contagious, right? But it can affect the pericardium and cause acute pericarditis. So a very common virus to see in our younger populations. Epstein-Barr virus, what's that also known as? Mono, correct. How common is mono in our college-age kids, right? They're sharing everything at that point, right? Mono is super common. And that, even though we think of it just causes extreme fatigue for an extended period of time, it can also affect the pericardium and cause this inflammatory process to begin. But there are other metabolic or other conditions that can cause this as well. So if you have a heart attack, that can trigger an inflammatory response in the pericardium. And when it happens like within 2 weeks of the heart attack, it's called acute pericarditis. When it happens more than 2 weeks, it's considered Dressler's syndrome. Okay? And we'll talk about why that's important to delineate this in a post-MI patient because the treatment is going to be a little different. Okay? If I do open heart surgery on a patient, let's say they needed a cabbage done to restore perfusion in the coronary artery, me just manipulating the pericardium can trigger an inflammatory process because it's got to heal from the surgery, right? That can precipitate acute pericarditis as well. And then you can see all these other things, connective tissue diseases like lupus, sarcoid, all those kinds of things. Those can all trigger this inflammatory process to affect the pericardial structure. Okay. So lots and lots of things that can cause this, and some of them pretty common in our society. But there are medications that can also cause this. So You can see on the last one, minoxidil. So if you have anybody who's follicularly challenged, like myself, who's taking minoxidil, that could trigger acute pericarditis. Okay, so maybe something we did, or maybe something that the patient got over the counter, but wasn't necessarily properly counseled about, could trigger this inflammatory process in the pericardium. So how does this inflammatory process lead to the inflammation of the pericardium and lead to the condition itself? Well, first of all, you have to have whatever that trigger is present, okay? So if it's Coxsackie virus, I have to be exposed to Coxsackie virus. That virus has to gain access to my body to then trigger all the other subsequent inflammatory response stuff, okay? So you gotta have that trigger. That trigger leads to increased vascular permeability, which means then I have all this fluid kind of shifting out of the blood vessels and into this space. Well, that then leads into a immune reaction where now you're having like leukocytes migrating into this space, which is really going to trigger that inflammatory process, because what is your immune system going to do? It's going to try to start fighting the infection, right? And part of that fighting is it's going to deposit fibrin, which then can lead to even more inflammation, which then can lead to the findings that we see in like a friction rub, and also the chest pain that these patients typically experience. If every patient who's diagnosed with acute pericarditis were to come in and get an open heart procedure done, this is what you may see in those patients, okay? So remember, we have about 15 milliliters or so of fluid in the pericardial space normally, but when I have this inflammatory process, kind of the beginning stages is you're going to see this very serous kind of fluid, which is very thin, okay? It could be like, okay, it's not normal pericardial fluid, but looking at that fluid on the top picture, it kind of looks like, okay, my frictionless environment probably is still preserved, right? But look at the serofibrinous, or the bread and butter discharge, or fluid that you see. Look at that. That's chunky, that's abrasive, that's not a frictionless environment anymore, right? And this is the most commonly one that we observe, just because we're not doing surgeries on the top patients, right? We're doing surgeries that's maybe on the lower patients when they're having this more complex, more symptom-causing kind of presence, fluid presence in that space. But look at it, does not look comfortable, and that's what's going to lead to that friction rub, because now you have friction there, and then also because it's going to lead to pain associated with it. But if you have a bacterial cause, this looks like pus, doesn't it? You basically have an abscess around the heart. And if you've ever seen a patient with an abscess, especially if they're very sick, it is extremely difficult to treat, and you usually carry a much higher mortality rate if you had this happen. And that's the case with suppurative pericarditis, because you have this overwhelming infection that's triggering this abscess around the heart. Chances are they tend to be possibly immunodeficient or immunocompromised, so they're not really able to fight the infection very well. You can see this snowball effect that this portends to a poor prognosis if you have this suppurative pericarditis. And then if you have cancer or tuberculosis, what you might observe is this muddy kind of discharge in the pericardial space. So how are you going to diagnose this, or what should make you suspicious that this is acute pericarditis? Well, most common symptom is going to be chest pain, okay? And you may not have a trigger or known trigger for this. Because the most common causes is this idiopathic / viral, right? Well, what does that idiopathic mean? We don't know, right? So these patients may not have a known trigger for this condition. But one of the things that you can elicit in your history to make you more suspicious for an acute pericarditis versus a STEMI or an acute coronary syndrome is the chest pain is positional. Meaning, when I sit up or I lean forward, the pain gets better. If I lay back, I cough, I sneeze, that pain gets worse. In a patient with acute coronary syndrome, which is also known as like a myocardial infarction, also known as a heart attack, positions are not going to change because you're not doing anything to change that perfusion in the coronary arteries that's causing that pain. So eliciting this positional chest pain history can really help you differentiate a heart attack versus pericarditis. Okay. But unfortunately, chest pain is not going to be a defining thing because, again, 95% of patients with acute pericarditis are going to have chest pain. They may have a fever, okay? And it may be what we call a low-grade fever, which I know Dr. Klein in pediatrics does not like the term low-grade fever, but they may have a low-grade fever. Maybe they're not quite 100.4, so they're not truly the definition of a fever, but maybe they're 100.0 or 100.1. It's not necessarily normal, it just doesn't meet the criteria for a fever. So they may have this. Now, if they have a temperature that's like 103, which for an adult, having a temperature of 103 is abnormal. In kids, it happens all the time, but in adults, 103 means this person is probably very sick. Okay? But if you have a really elevated temperature, then you should be suspicious that this is a bacterial cause of their pericarditis. Although, even though fever is present and it should make you concerned for bacterial, if you have a patient with a fever, the most likely cause still is viral. Okay. On exam, you may hear a pericardial friction rub, which just kind of sounds like Rice Krispies, the cereal when you put milk in it, that snap, crackle, pop, right? That's what you might hear on auscultation, typically at like the apex or the left sternal or the left lower sternal border. You may hear this the best, but that friction rub is something that you can appreciate. But with acute pericarditis, this inflammatory process could lead to significant complications. So how do you know if this patient has risk factors or concerns for having severe complications related to this? And this is where you have to look at your red flags. So fever greater than 100.4 with a leukocytosis on your CBC should make you concerned that this is maybe something a little more involved and probably should require a hospitalization. Because not all patients with pericarditis need to be hospitalized. If you have a low-risk patient, then they don't need to be coming in the hospital. They can just be followed as an outpatient. If they have a large pericardial effusion or tamponade, then they definitely need to be hospitalized because you're going to need to do some interventions to treat that, right? If they're immunocompromised, portends to worse outcomes even with a viral etiology. So to diagnose this patient, you have to have at least 2 of the following symptoms or conditions. Okay, so typical chest pain, Okay, we talked about it being positional. On auscultation, they have pericardial friction rub. EKG findings that are suggestive, which we'll, I think on the next slide we'll review what those look like. Or if they have a new or worsening pericardial effusion, so if they have excess fluid accumulating in that space, then that is a potentially a item that can help you diagnose this condition. But don't lock in on acute pericarditis. You've got to keep your differential up because you need to make sure that these other things are not going on. For instance, acute coronary syndrome, so a heart attack, aortic dissection, especially if this is one of the symptoms you're using, because the aortic dissection could cause excess blood to accumulate in that pericardial space. And when we talk about cardiac tamponade, you'll see why that would be something to be concerned about. So your EKG, so about 90% of your patients are going to have these typical findings to kind of point you or direct you to this being acute pericarditis, okay? One of the common ones that we all know about is just that diffuse ST elevation. So the ST elevations are not localized to a particular coronary artery distribution. So this would be like, this person has a anteroseptolateral and inferior wall MI. Well, that doesn't make sense, right? Unless we're knocking out the entire left and right coronary arteries. That doesn't make sense that you're going to have a true heart attack triggering that. So you may see this diffuse ST elevations. Spottic sign, I don't know, did you guys talk about that in EKG? Okay, spottic sign is this downsloping T to P segment. So you can kind of get an idea here in lead V4 here, you see where the T wave ends and then it downslopes to the P wave to get it back to baseline. And then the next cardiac cycle starts, that P wave is triggered at baseline. And you can kind of see it in this lead up here, just that downsloping into that T to P segment, okay? But only 90% of patients have abnormal EKGs. So the other 10 will have normal EKGs, okay? So be careful of those 10% with a normal EKG, which is why you just need 2 of those symptoms or those signs that we talked about on the previous slide to actually be able to diagnose acute pericarditis. So what other things can we find on our ancillary studies with acute pericarditis? It could be completely normal. You may not see anything on there to suggest acute pericarditis. But if you have complications developing like excess fluid, a pericardial effusion present, you're going to see a distortion of the pericardium or the cardiac silhouette on like your chest x-ray. Or on your CT scan, you may see that present as well. And you can kind of see, this is what the water bottle sign looks like. Okay, so again, you said it's not one of your Nalgene bottles or your Yetis or whatever, the Stanleys that they have now. This is an old school water bottle, and that's what the water bottle sign comes from. This CT, you can kind of see, here's your, one layer of your pericardium, the other layer of your pericardium. You see all this mass here, that's all fluid, so that's a pericardial effusion present in the setting of acute pericarditis. You're going to want to get an echo on all of these patients, okay? Because you're looking for complications, okay? And when you do an echo, if it's normal or kind of borderline, you're going to want to have the cardiologist repeat this echo in about 2 weeks, okay? And the reason for it is we want to, okay, they were fine now, but give them some time. Did they develop some of those additional complications that we need to be aware of, okay? So you're going to want an echo at a time of diagnosis, and then you're going to want to repeat that at least 1 to 2 weeks to make sure they didn't develop a complication. Now, if they have a lot of fluid, like that pericardial effusion that can develop is large enough, you may need to even be doing some urgent procedures to correct the deficiency so that they don't decompensate and go into heart failure and die. So you may need to do something. When it comes to the additional workup like labs, don't shotgun your approach, okay? Don't do the ER method where anybody coming in with chest pain gets a battery of these 10 tests, okay? I don't care what their risk factors are. Everybody with chest pain is getting troponins, CBC, ESR, CRP, blah, blah, blah. Target your workup based on what you suspect is the problem, okay? ESR, CRP is going to be elevated because this is an inflammatory process, okay? But how many other inflammatory processes cause elevated ESR, CRPs? All of them, right? So how helpful is that going to be? You could do a CBC to look for their leukocytes to make sure they don't have like a elevated neutrophil count. This would make you suspicious for a bacterial cause. But just know that in a lot of patients, that is normal. If you have a patient with lupus, or you suspect has lupus, yeah, sure, go ahead and order a lupus panel to make sure that that's not the cause or the trigger for this. But don't order all of these tests unless you suspect there's a different etiology other than like a virus. Okay. Fortunately, remember we said that the vast majority of patients with acute pericarditis never come to see us in medical for a diagnosis and treatment. So even if we don't do anything, chances are they're going to get better. Okay? But why would we want somebody to have to deal with chest pain that otherwise is bad enough that they came to see you in the first place? And remember, we talked about complications developing from this. What can we do to decrease the risk or chance of having these complications develop? And that's where the treatment usually comes in to help address those two concerns, where typically we're going to give them this colchicine plus an NSAID. That is the typical treatment, and the NSAID can be Motrin or ibuprofen. It could be indomethacin. It could be naproxen, or it could even be aspirin. Okay, so any of those plus colchicine is your treatment of choice for acute pericarditis because it will help with the pain, help with the inflammation, and decrease risk of complications developing in the future. Okay. And you're going to want to do at least 2 weeks of treatment for this to minimize scarring and the development of the last pericardial condition that we're going to talk about today. Be careful if they are on anticoagulants or something else. Be careful of giving them an NSAID or aspirin because that could affect and make that anticoagulant work stronger, and now they're having bleeding issues, like a hemorrhagic stroke or something like that, that can cause other morbidity and mortality. Remember when we talked about a post-MI cause of acute pericarditis, and we said to be careful about that because the treatment's got to be a little different? Well, the reason is, what happens when you have somebody with an MI? They have cell death, right? Dead cells, dead tissue doesn't stay dead. Your body's going to go in and it's going to remove the dead stuff and replace it with a scar, right? That's an inflammatory process. So if I'm giving steroids or if I'm giving an anti-inflammatory like an NSAID, and I want that scar to develop, what are those medications going to do in that setting? It's going to prevent the scar, or at least make the scar not as strong. Okay? Well, what happens with the pressure in the left ventricle? It's pretty high. So if I don't have a strong enough scar to replace those dead cells, I'm going to increase the chance of risk of that ventricular wall rupturing, and then the patient's going to bleed out and die quickly. Okay? So in a post-MI patient, don't give them ibuprofen, don't give them indomethacin, don't give them naproxen. You give them aspirin and the colchicine. Okay? So in a heart attack or post-heart attack patient, the treatment has to be aspirin and colchicine. If it's not because of a heart attack, then you can give any NSAID with the colchicine and you're okay. Okay? Does that make sense?
So we're using aspirin just because it has a weaker overall anti-inflammatory effect at that point?
Exactly. Yeah. Yeah. But it gives you that pain control that you get with the other NSAIDs, but with less of an effect on the inflammatory response. Yeah. Yeah. Okay. So aspirin and colchicine post heart attack MI, or acute pericarditis post MI. Now, what can happen in the long term? Well, if I had acute pericarditis develop once, I'm at a higher risk of having acute pericarditis develop again, right? If I've had something once, I'm at a higher risk of having it again. I can then also, inflammation is a scarring kind of process, right? Well, that pericardium should expand to an extent, but if I scar, I'm not going to get that expansion, and now it becomes constrictive pericardial disease, which we'll talk about in our lecture today. But that's going to then start to affect the actual function and the expansion of the heart during the normal cardiac cycle. So big thing from a follow-up standpoint, so we said you're going to want to follow up 2 to 4 weeks. They're going to need another echo, just to make sure they haven't developed a complication. But you're going to want them to avoid strenuous activity for at least 4 weeks. Because the concern is they've already had inflammation of the pericardium. What's adjacent to the pericardium? The myocardium. So does that inflammatory process affect the myocardium or the muscle of the heart? So you want to avoid strenuous activity for at least 4 weeks. If they're an athlete, it may even be longer. Okay. So this would be, from a military standpoint, these people are being put on profiles or light duty or whatever the Air Force calls it, to remove them from doing PT or doing PT tests, heavy lifting, field exercises, all those kinds of things. Okay. Questions about the acute pericarditis?
So what is serial TTEs?
So you're going to repeat the transthoracic echoes. Yep. So you're going to do that initially. 2 weeks later, you're going to repeat it again. And then, depending on what you see on that repeat, you may need to do it again 1 to 2 weeks later, kind of thing. But your cardiologist will drive that decision making. Okay. So that was just the condition of the inflammation of the pericardium. Okay? But what happens if we have too much fluid that accumulates in that pericardial space? And this is the term pericardial effusion, so fluid in the pericardium, where now, instead of having that 15 to 50 milliliters of fluid in there to create that frictionless environment, let's now say we have 75, 100, 150 milliliters. What are we going to see, and what's going to be the outcomes from that? Okay. Recall what we said, the most common cause of acute pericarditis being this idiopathic/viral. Look at what the most common cause of a pericardial effusion is in the United States. It's cancer, right? You have these cancer syndromes that develop as part of the condition itself. And part of that is that you get this fluid starts to accumulate in other spaces that it normally shouldn't. Somebody has breast cancer and they get radiation therapy to the chest. That can affect the heart, which then can lead to this effusion developing. We just talked about one of the potential complications of acute pericarditis is a pericardial effusion. Well, here's your viruses now, but 14% of cases of pericardial effusion in the United States is because of a virus and not something else. So you can kind of see that. What's interesting is hypothyroid. We say the thyroid affects every organ system in the body, right? I know you haven't done endo yet, but what's interesting is hypothyroidism, one of the symptoms is edema associated with it. And that edema will go anywhere. Normally we think of in like the pretibial area, but that edema can go to the pericardial space and lead to a pericardial effusion. So now imagine what the treatment of that's going to be. It's not necessarily just drain the fluid out, because you still have the condition that's triggering this event there. So you're going to need to treat that hypothyroidism to alleviate the cause of that effusion. How are they going to present with a pericardial effusion? It kind of depends on how much fluid is there. Okay? They could be completely asymptomatic, no problems, but if they have a significant volume in that space, then they actually could present as cardiac tamponade. Okay? So we'll talk about cardiac tamponade in the next pathology. But the presentation is going to be very broad and variable, and it's because of how much volume is in that space, what its effects are on the heart, functional effects on the heart, and also how quickly did that fluid accumulate. If something accumulates faster, then you're going to become symptomatic faster, right? If it's a slow kind of process, your body can adjust and compensate for that, okay? So how fast and how much can really impact how they present to you. Now, yes, they could be completely asymptomatic, but some of the symptoms they may have is actually effects of that excess fluid impacting other structures. So you've got the lungs on either side of the heart. Well, now that fluid is expanded so much, now it's putting pressure and collapsing lungs. So maybe now they're going to have dyspnea, so the shortness of breath, they may have other problems breathing. It may hit the recurrent laryngeal nerve, so now they start to have hoarseness present. It could hit the phrenic nerve, and now they're having hiccups, uncontrolled hiccups. So you can see it's not necessarily a cardiac complaint that could trigger this or make you suspicious for pericardial effusion. It's other structures being impacted by it. On physical, if it's severe enough to cause tamponade, you may see this Beck's triad that we're going to talk about. But one of the big things is Ewart's sign. Okay, so this is a dullness percussion over the left posterior lung because you're percussing over that extra fluid. You're percussing over a solid structure as opposed to a structure that's full of air. Okay. Other things you might see, if you did an EKG, you may have just a low voltage, but if the effusion is bad enough, you may actually get this electrical alternans where, look at the amplitude of this QRS compared to this QRS. You see it's different. And as you march down this rhythm strip, you see it's different from beat to beat to beat. And the reason is, this time it beats, the heart's towards the lead, so it's going to have a big amplitude. The next one, it's going to swing away from it, and now it's farther, and it's going to decrease that amplitude. Okay, if I have excess fluid, that heart's going to be able to kind of freely flow around and move around however it wants. Kind of think of it as like a baby in utero with the amniotic fluid around it. It can do somersaults in there if it wanted to, right? So that's what the heart's doing in pericardial effusion, especially in a large effusion. Echo is going to be your test of choice because, one, it's highly accurate as far as the it can detect as little as 20 milliliters of fluid in the pericardial space, but it can also then help you with the treatment aspect if you needed to pursue treatment. Okay. That's 50 minutes. Let's go ahead and take a break. Come back at 11, and we'll finish up.
Spa day. That would be nice too. What does she like?
Oh.
I'm trying to get so much
Like watch I can tell. You take a lot of things. You take a lot of things.
I don't get the
What ones do you pick up on? Like, oh,
the ones I do.
what style? I know there's different styles. You have to be.
Not that funny, but.
I hope that a lot of like too much dogs.
I used to.
Like, is there a show?
I was watching Sandman. I watched Sandman on HBO. Her accent is so funny. The dialogue is like really funny.
Okay, so his joke was bomb. When so it's in your is his name.
Yeah, I know. That's why I thought it was a
Nathan
few
is
creative.
a brand of yeah, it's like a brand.
You're not gonna make your wife a hot dog for
Yeah,
breakfast.
but it's gonna give anyone Nathan's hot dog. He asked me what
Oh, for breakfast? I guess. Brush your teeth.
So I'm just gonna get it and then see what you're saying.
That's what I just said.
Oh, well, I asked you if you got it. You're like, oh, just like,
Yeah, I just,
okay, all right, you got it.
you're fake.
I thought it was a bomb. I laughed. What are you getting your husband?
Typically it's towards.
Yeah, it's equal rights, dude.
Equal rights, equal
Equal rights.
I think that's more like a specialty. Transplant donations.
I think the difference is it is just.
Exactly.
But I think what I'm saying is I think you were going
My happiness.
down there.
Sorry. Your happiness revolves around him. He doesn't give you.
You won't see.
No, attention, not necessarily a guy.
Yeah, like,
See, you don't know how they based around relationships. So we're asking, what are you doing to show that appreciation?
I have a Rolex.
I'll do my
I have a
hair.
rope I'll take that again. That's like an ancillary.
I have a watch.
What?
Here's the sugar
He
bar.
doesn't, he has 2 watches already.
Oh, two.
Yeah, he wears like one of those, what was it called? The band, and then he wears another watch with the other.
She said that like, do you even know? Is the point maybe that like guys can so to create a female?
In any relationship, are you looking at this rate as a great for any relationship? Every person has a certain language. We have, but they have a primary and they have like a, they'll set for them.
Yeah, no wonder you're funny.
Yeah, there's like
What?
acts of kindness, physical touch, gift giving.
I hate those tests.
Is it something
Is
that's
it like, it
service?
reminds me of like personality?
Well, acts of service, acts of kindness, obviously yours is gift giving. I give you a gift. It's not like
But it doesn't have to be like an expensive. It could
The
just be
law
like a
that you're like, oh,
That's
okay,
right.
that's
Yes,
just this. And, you know, that's not.
Yes, it doesn't have to be expensive. It's just the sentimental value goes a long way too. No, but it's part of that love language.
That's
Part of the love language.
I didn't say you didn't see the vision, all you hear about is the consideration. But like you like gifts, like you like.
Because it has sentimental value.
So if
Yes, which that is your love
husband
language.
likes kissing, then obviously he likes physical touch.
I think
It's
it's
not a bad
nice.
thing. I enjoy giving, I just don't like receiving.
You see? Yeah.
I think it's like a self-worth thing, but I'm not worried about receiving.
Like acts of pressure.
Yeah.
What's your love language? See? She says that, and I say, who does?
You say your husband.
Oh, yeah.
No one judges me. Maybe for not knowing his love language.
It's just, you see, he's like a very basic.
But he does have something like maybe he likes just for you to be around him. Just to be like, okay, well that is.
So see, that's the answer. What are you
Talk
gonna
about
give
as
your
a
husband?
love language.
We're not gonna get into it. He's just saying that there's certain ways people show.
Like, see, because if you said, hey, is this me being around and getting to see me, getting to hang out, more time than they would like, try to do something that way I can be around you. That's what I'm trying to do. Just being around you, but you're just learning to use it.
It's kind of like you're showing love in a way that you think you're showing it in a way that it's like you're not showing love in marriage.
Because if I don't care about
He's just giving us an example. It's not necessarily true. That's why I'm saying when you know how the other person like says love.
I like it switch me up.
Give you that.
No, I'm not gonna get sad.
Get all riled up. That's all they're saying is like everyone's like this love.
So when we ask,
I just don't want to hear that.
I myself, I'm like, I gotta do, also, you believe,
That's how you like it.
We're on stage.
Maybe this one. So he just gave you a hug.
Yeah. Right, you got 11 o'clock on the clock. Get back to it.
If you remember, that'll be good.
Okay, so we're talking about pericardial effusion, and we were talking about kind of some signs and symptoms and some of the ancillary studies that you may get that have different results. When it comes to labs, similar to what we talked about with acute pericarditis, don't shotgun the approach. Try to have an idea based on your history what the potential cause is. Okay, hey, they have a malignancy. Okay, well that's probably the cause of it, right? Why do I need to look for some of these other things like lupus or something like that if I suspect that it's due to a malignancy? What can help you differentiate what the potential cause is if actually you get a sample of that fluid via sticking a needle into that space and drawing back on that fluid. You can actually analyze it and get an idea. We'll talk about it in the next section, how you can do that. But it can give you an idea of what the cause is, which may guide then further testing based on what you suspect is going on. Okay. So how do you treat it? Well, if I have, we said up to 50 milliliters is a normal volume. If I have 55 milliliters in that pericardial space, technically it meets the definition of a pericardial effusion, but they're probably not symptomatic. So do I really need to do anything about it? And the answer is no, right? Even, the treatment of sticking a needle into the pericardial space and taking all that extra fluid, one, I run the risk of damaging other structures, right, by sticking a needle into that area. But two, I also introduce the risk of infection. So I may not need to do something because the harm may outweigh the benefit by doing a procedure. But if they have moderate to severe disease, so they're having symptoms from this, then you definitely are going to want to do a pericardiocentesis, so sticking a needle into that space to withdraw that fluid, or as much of that fluid as you can. And if it comes back, let's say they have cancer, and that fluid reaccumulates after I removed that fluid, I could either stick another needle in there and pull back, or I could put a drain in there so that I can always just kind of open the drain the fluid out, close it. Although that increases risk of infection, so this might be like a hospice kind of treatment, right? The patient's going to die soon anyways, but I'll make them more comfortable in their last few days. Last resort is if that fluid continues to reaccumulate, is otomy is a hole. I can create a hole in the pericardium. Okay, so now any fluid that accumulates then will escape the pericardial sac and dump into the surrounding structures and then get reabsorbed like in the pleural space or some other space like that. Okay, but pericardiotomy or pericardiectomy is a hole. Or sorry, otomy is a hole, ectomy is removal. So yeah. Okay. All right. So let's say that effusion is now large enough or it accumulated too quickly that now it's actually interfering with the function of the heart. And that is the definition of a cardiac tamponade, is that function and that fluid accumulation is now disrupting the normal function of the heart. Okay? because what's happening is it's exerting an inward pressure on the heart, so it can't expand normally to take in preload to convert it into stroke volume and afterload. So the same things that can cause pericardial effusion can also cause a cardiac tamponade, but you also need to add in the trauma aspect of this. So you'll see this with like, a unrestrained driver in a motor vehicle accident who gets blunt chest trauma from their chest hitting the steering wheel after they crashed. That can disrupt and cause trauma to lead to an acute development of that effusion, i.e. blood bleeding into that space, causing cardiac tamponade. You can also see this with blast injuries. You can also see this in, remember we talked about acute pericarditis and using NSAIDs in a post-MI. If that ventricular wall were to rupture because of that MI and that weakening of the ventricle wall, now all that blood is going into the pericardial space, and that can cause an acute development of cardiac tamponade. And the symptoms and the presentation is going to depend on how rapid did this fluid accumulate, okay? If I have blunt chest trauma in a motor vehicle accident and I'm bleeding into the pericardial space, you'll see with smaller volumes, all of a sudden that pressure is going to quickly rise because your body's not able to compensate and adjust for that extra volume. Okay. Oppose that to something that's like a slow accumulation. You can see my tolerance for the volume is going to be much higher before I start to get that pressure increase. Okay. Eventually you're going to get to a volume where it's going to increase the pressure, but I'm able to compensate and accommodate that extra volume for an extended period of time if it's slower and you give me the time to accommodate it. But the key thing on physical exam you're going to see with the patient with cardiac tamponade is Beck's triad. Okay? Beck's triad is hypotension, and the hypotension is because you're not generating an adequate stroke volume cardiac output to maintain blood pressure. Okay? You're going to get JVD because all that inward direction of pressure that's causing the heart to not be able to expand, to take on preload, is going to lead to a backup of preload into the peripheral venous system. So that's going to lead to the JVD. And then you get muffled heart sounds because you have all that extra fluid surrounding the heart, so you're not you're increasing that distance of your stethoscope to the actual heart valves. So Beck's triad is hypotension, JVD, muffled heart sounds. So if you see that, you have to be suspicious for cardiac tamponade. Okay. Other things you might have seen, or you might see, especially if you're doing like invasive monitoring, is typically you get a loss of the Y descent on the jugular venous pulsation waves, right? Remember we talked about jugular venous pulsation waves in the second lecture of this block. The Y descent, you can see on this normal thing here. This is, the peak here is when the tricuspid valve is still closed, but now you have the peak kind of pressure in the atria, and then the Y descent is the tricuspid valve opens, and now all that volume is quickly dumping into an empty right ventricle, and then it accommodates that volume, and that pressure slowly starts to rise. Well, in cardiac tamponade, you lose this because you constantly have this inward pressure being exerted on the heart, that when that tricuspid valve opens, your ventricle is not going to open to take on that volume. So now I have that resistance to expansion, I have that resistance to or reduced compliance of the right ventricle, so that a little amount of volume is going to quickly raise my pressure. So you can see in the example of a patient with cardiac tamponade, that Y descent is much different compared to what it normally should be, because the right ventricle is not allowed to expand to accommodate all that volume coming from the right atria and into the right ventricle when that tricuspid valve opens. Okay? Does that make sense why you lose that Y descent? Similar to what we talked about with the pericardial effusion, because I have all this extra volume on my EKG, I may see low voltage, and I also may see this electrical alternans where the amplitude of the QRS is going to be different from beat to beat to beat. Echocardiogram is going to be your test of choice because you're going to be able to visualize the fluid, but then it also sets you up for the actual treatment of it too. For labs, again, don't shotgun this. If somebody was in a motor vehicle accident and they had that blunt chest trauma, why do I need to do a CBC? Why do I need to do viral panels to figure out why they developed? So I have the answer. So test according to what you suspect is the cause of their cardiac tamponade. And then the pericardium, if you did have it where you're like, I still don't know what this is, your pericardiocentesis, getting that fluid out of the pericardial space, allows you to analyze it using Light's criteria, and kind of get a general idea of what the cause is. Now, I don't want you to memorize Light's criteria, what the criteria are, okay? Just knowing that Light's criteria can help you in the diagnosis is really all I want you to know, because you're going to be having calculators to help you do this, okay? But with Light's criteria, based on the analysis of that fluid that I got with the pericardiocentesis, I can get an idea, okay, if spec grav is greater than 1.015, then I'm concerned that this is a malignancy, I'm concerned that this is infectious, this may be post-pericardiotomy syndrome, or it may be even a collagen vascular disease, okay? That would be a exudative fluid. But if that spec grav is less than 1.015, this is a transudative fluid, and now I'm concerned that this patient has had radiation, they have uremia, they have hypothyroidism, or even trauma triggering this. So just analyzing that fluid in a questionable etiology can help you at least narrow down what the cause is. Treatment, okay, ultimately you've got to get that fluid out of that space. Because I need to get that fluid, I need to get that excess inward pressure off of the heart to restore function. And the ways that I can do that is I can stick a needle in, under ultrasound guidance preferably, and draw back and aspirate all that fluid out. You may need one of those like 50 cc syringes to accommodate all that volume. If you have like a little 5 or a 10 cc syringe, you're going to be pulling back a lot and squirting. If you have like 200 milliliters in there, right? So you're going to need a big syringe. They may go in and do where they create a little window that you see in that bottom image there, where like let's say that this patient has a malignancy or uremia or something like that, and that fluid is going to reaccumulate regardless of you drawing back the fluid. I create that window, and now it just dumps into other spaces and gets reabsorbed. But that's typically the treatment for cardiac tamponade. It's a medical emergency if somebody is diagnosed with cardiac tamponade. Okay. Now the last pericardial disease that we're going to talk about is constrictive pericarditis. Okay. This is basically, think of this as a scarring of the pericardium itself. Okay. What do scars do? They're stiff, oftentimes they're calcified. they're not going to stretch and accommodate expansion of the heart and that kind of stuff. So it constricts the heart, okay? And typically, when we look at it, especially in developed countries like the United States, the most common cause for this condition is they had acute pericarditis years ago, and maybe they didn't get their colchicine NSAID treatment, and now they developed that scar tissue in the pericardium itself. Okay, so the vast majority of cases in developed countries is basically a complication of acute pericarditis. Okay. But you can see there's other things that can trigger this. And basically, a lot of these are very similar to the causes of the other things we talked about with like the effusions and the pericarditis and stuff like that. So the same things can lead to a chronic scarring or chronic calcification of this sac. But when you look at the physiologic changes that occur with constrictive pericarditis, the physiologic outcomes are basically the same as cardiac tamponade. Okay? So my ventricles cannot accommodate preload. They can't stretch to take on this preload to generate a stroke volume. So that's then going to lead to a backup of that preload into the structures upstream from it, right? That's going to increase your venous pressures. It's going to impair your stroke volume. So ultimately what happens is you get jugular venous distension, you get backup in the lungs, you get pulmonary rales, you get that pulmonary congestion. And then the forward cardiac output issues leads to hypotension, reflex tachycardia, and then death. So think of this as a diastolic problem, okay? Your ventricles, they will get whatever volume comes to them out during systole. The ventricles themselves will squeeze. It's the filling that's the problem in this condition, okay? And these patients, if they have constrictive pericarditis, they may be symptomatic. It's going to be kind of like an indolent kind of condition where it's going to take time to develop that scar tissue and stuff, and really to develop that constrictive property. But think of then, they're going to then lead to heart failure kind of symptoms. So they're going to have decreased exercise tolerance, they're going to have shortness of breath, they're going to have JVD, all those kinds of things developing because of that heart failure. Kussmaul's sign, remember we talked about looking at the jugular venous pulsation wave. It normally should drop with inspiration, but in Kussmaul's sign, because the right ventricle is the problem, that jugular venous pulsation wave actually increases with inspiration. So you're going to see this in constrictive pericarditis. Okay. Other things on ancillary studies, so chest x-ray, you may see calcifications of the pericardium because of that scar tissue formation. EKG may be nonspecific, maybe low voltage present because now you got this scar tissue surrounding the heart. It's not going to be as easy to detect those action potentials going through the conductive pathways. Echocardiogram, you're going to see like the thickening, the calcification of the pericardium, and then cardiac MRI is actually indicated in these patients because the treatment is surgery. And we said cardiac MRI is good in surgical planning for cardiac disease. Okay? So cardiac MRI can help with surgical planning. Other things. So we talked about in cardiac tamponade, you lose that Y descent because of that constant inward pressure on your jugular venous pulsation waveform. But in constrictive pericarditis, you actually have a prominent Y descent. And you may be wondering, well, if this condition mimics cardiac tamponade, why is there a difference in this filling pressure in the right ventricle that leads to this change in the jugular venous pulsation waves? And the answer is, with cardiac tamponade, you have a constant pressure exertion on the heart to restrict that ventricle from opening, right? In constrictive pericarditis, I have this rigid structure, but if my heart is smaller than that rigid structure, I'm going to be able to compensate and open up to an extent, right? Well, as I am opening up and I have that compliance, I'm taking on all this extra volume, so you'll see that volume and that pressure drop. But then you're going to get to the point where it can't expand anymore because you have that scar tissue, and now that pressure quickly rises up. And you see that on the Y descent here on the jugular venous pulsation wave where right here, that tricuspid valve opens, you get that quick flow of blood from the right atria into the right ventricle. It then reaches the point where it will no longer compensate or that compliance, it can't open up anymore, and now that pressure rapidly increases, right? Compare that to normal, where that pressure rise is slow. Okay. So loss of Y descent in cardiac tamponade with that constant inward pressure, a prominent Y descent in cardiac constrictive pericarditis because that right ventricle will open to an extent. Okay. Now that Y descent, as the condition gets worse, is going to become smaller and smaller, but you at least get movement to an extent from the right atria into the right ventricle. But you can imagine if this is a chronic thing and this is scar tissue, how do you fix it? I can't give them a magic pill to reverse chronic changes to the pericardium, right? There's no magic medicine I can give to them. A steroid is not going to do anything because the damage is already done. The inflammatory process that triggered this scar tissue has already done its damage. So ultimately, the only thing that you can do to fix this condition is to remove the entire pericardium from around the heart. But you can see that's not an easy procedure to do. 20% of patients are going to die in the OR doing it. So risk-benefit discussions, right? But of the 80% who survive the surgery, 90% of them are going to see such a significant improvement in their quality of life that it may be worth it in that case to deal with the 20% mortality rate. Okay? But you can imagine it's a difficult decision your patient's going to have to make. Do I accept a 20% chance I'm going to die on the operating table doing this procedure? Or do I accept a 90% chance that if I survive it, I can actually get out of bed? So it's a tough decision. Fortunately, you as a primary care PA will not have to make with your patient. Now, if you become a cardiothoracic PA, you may be having to have that discussion, okay? But that's if you want to subspecialize later in your life. Questions about pericardial inflammatory diseases before we finish up quick with our myocardial inflammatory disease. Okay. So this was actually a topic that was added to the 2025 PANTS blueprint. The prior edition actually did not have this condition as a required topic to know about. And I think what triggered this is this became a headline starting in 2020. What happened in 2020? COVID. So COVID itself can trigger myocarditis, and vaccines for COVID could trigger myocarditis. So the question is it the vaccine that's causing it, or is it they get exposed to COVID and it triggered it, or is it both? Who knows? But we've been seeing a lot more cases of myocarditis because of COVID and vaccines associated to treat COVID. So I think that's why this topic was added to 2025 Enhanced Blueprint. It's not that common in the United States. So you can see 6.1 in every 100,000 people are going to experience myocarditis. But there is a mortality rate that's associated with this condition. And this is why people were so concerned. Because if we had, let's say, a 0.01% chance after getting the Pfizer COVID vaccine of getting myocarditis, okay, we're giving it to millions of people, you're now having 1Z, 2Z, 3Z, 10Zs of people developing this condition. But if they develop this condition, there's a mortality risk for it. So now, you're having people die from a complication associated with the vaccine, even though the risk of that complication is very, very small. There's a chance with polio vaccine of you getting reactivated polio, right? We don't really think of it. It used to be in the United States, the only polio that we were seeing was those cases, which there was just a handful of it. But now, because we have that vaccine hesitancy, we're now seeing polio cases starting to come back, in addition to measles and all those other things. And now we're dealing with consequences of these diseases that we thought were once eradicated. But look at the cause of myocarditis. A lot of these are not new. A lot of these were attributable to acute pericarditis, but we said adjacent to the pericardium is your myocardium. So that inflammatory process got through the pericardium and now has gotten into the myocardium and is causing this inflammatory response to occur in the muscle itself. But you can see some other things. We don't really have much of T. cruzi or diphtheria or Borrelia or Q fever, those types of things in the United States. However, when you, as an active duty member, deploy to a region, you may have to think about these diseases because it may be present in that location. How are they going to present? It could be variable. So it could be that they are completely asymptomatic, maybe just mild chest pain that doesn't really affect their life. It could be that they come in cardiogenic shock, or they could just drop dead. Okay, so great. You've got a pathology that can present with no symptoms at all, or death. What do you want to be you, right? So it makes it difficult to diagnose because there's not a consistent thing where 99% of your patients are going to present with these symptoms. Okay? So it's hard to diagnose this condition because the presentation is so variable. What can you see on exam? It's really going to depend on how bad it is, but you may have signs of heart failure because the function of the heart, because that muscle, that inflammatory response in the muscle is impacting the function. You may see that, which means then you can have JVD. You may have like edema, peripheral edema, gut edema. You may have pulmonary congestion, all those things. You may even have new murmurs develop because of that inflammatory response that's there. EKG, non-specific, but you may have diffuse ST elevations like pericarditis because you could have a condition where you have myopericarditis, where you have both inflammation of the myocardium and the pericardium. So you may have the diffuse ST elevations on the EKG. You may have what looks like localized ST elevations because that inflammation of the muscle itself could impact perfusion to that area. So it actually is going to mimic a STEMI. but it actually is an inflammatory process that's causing the perfusion, not a plaque or a clot that's causing that perfusion problem. Chest x-ray, not very helpful. Labs, this is an inflammatory process, so your ESR-CRP will be positive. Your cardiac enzymes, so your troponins are going to be positive. But if you're still like wondering, well, is this a STEMI or is this something else? Then I can always get a biopsy of the heart muscle itself, and then I can use Dallas criteria that you see at the bottom of the slide to help me with the diagnosis of this condition. Okay, so we talked about Dallas criteria here. We talked about Duke's criteria when we talked about infective endocarditis, right? So keep those kind of straight because you may see that on Monday. So, but Dallas criteria can help you diagnose this condition if you are still questioning the actual diagnosis. How you treat it? Well, again, it's going to depend on their presentation. If they're asymptomatic, okay, it could be just, give them some stuff for inflammation and some pain, and then they'll be fine. If they're presenting with heart failure, you may need to be addressing the heart failure symptoms. If they're coming in with cardiac arrest, well, that completely changes your treatment algorithm, right? So the treatment's going to be kind of dependent on how they present. But that brings us to the end of block 1. And you can see even just 3 lectures of having, actually infective endocarditis should be marked off on there too. But you can see even with just 3 lectures of newish material, we still got quite a bit of our PANCE blueprint marked off. So, do I have any questions? All right, I uploaded the review slides before I came in here. So you can download those if you want to start studying, which I know Pole is really on your mind right now. But those review slides are there. We will go through those slides tomorrow during our lecture. And then the lab will actually be an opportunity to take all of this information and now apply it to questions similar to the ones you're going to see on Monday to see if you can take all that information and actually apply it to like a patient scenario in those kinds of things. So folks usually really appreciate the labs or like the labs because it's a good study opportunity, active study opportunity to use the information that you're learning before you get to the test. So, otherwise, I'll see you all tomorrow.